When we look at the different fluids of origin, we've kind of touched on a little bit of them, like the hylothorax. We talked about that with the hepatic system. We're going to talk about the chylothorax and the other fluids of origin right now. Oh, chylothorax. So when we look at the chylothorax, this is a milky liquid that is produced from food in the small intestines during digestion. So when we look at the chyle, so the chyle is the milky liquid. A chylothorax is that milky liquid that moves into the pleural space. Normally, it's absorbed by the lacteals in the thoracic ducts in the neck, and it's mixed with the blood. But you can have patients that have a trauma to the neck, that will impact the ability for the body to absorb the lacteals in these thoracic ducts. So trauma to the neck or the thorax or even a cancer can lead to a chylothorax. So the way I remembered this in school is I've always been a huge Batman fan. I remember as a kid that I even tried to jump off of our mantle with the rope of our blinds around my neck so I could fly like Batman. My mom told me that story. I did two other things that are just insanity, things that you do as a toddler boy. But I remember that Batman was always one of my favorite superheroes. And the very first Batman, actually it's the second Batman with Tim Burton and Michael Keaton, when he's fighting off the Penguin and Catwoman. Well, Selina Kyle is this woman's name, and she's Catwoman in the very Batman Returns. It's the second Batman. And so I associated Selina Kyle to Catwoman to remember that a chylothorax is a milky substance that's secreted or produced by the small intestine during digestion. So you get a nice picture of Selina Kyle drinking milk because she is the Catwoman in Tim Burton's Batman. When we talk about a hemothorax is blood in the pleural space. This is going to happen from some sort of trauma, whether it's penetrating trauma or blunt chest trauma, whether that's a stab, gunshot, impaled object, or a blunt trauma being a force hitting your thoracic cavity. This can be iatrogenic. What does iatrogenic mean? It means we caused it. We caused it. This can be the insertion of a central venous catheter or an internal jugular central line. It can happen from the subclavian vein as well. We could see this with pulmonary artery catheters or a Swan-Ganz catheter. And the way that we differentiate between a hemothorax and a hylothorax, the way that we differentiate between the hemithorax, the way that we differentiate between a hemothorax and a hylothorax is the hemothorax is going to have a hematocrit of pleural fluid that is greater than 50%. So if the pleural fluid is greater than 50% hematocrit, we call it a hemothorax. If it's less than 50%, we call it a hylothorax. Hemothorax, hylothorax. 50%. If it's greater than, hemo. If it's less than, hylo. So what's your patient going to present like when they show up to the hospital? What are you going to see with all of these changes? You've got fluid that is occupying the pleural space. You've got the shift. You've got the atelectasis. You've got a lot of not even as much pathophysiology as we've seen with other disorders. But when you see this, you've got a increase in the heart rate. You got an increase in the respiratory rate, secondary to the hypoxemia, because you have oxygen that's not going to, because you've got less alveoli that are going to work. Your temperature is going to be normal unless you have a empyema. If you have an empyema, then you could have an elevated temp, and your saturations are going to be low. When we look at the IPPA, you're going to have a decrease in chest expansion, typically on the affected side. Your unaffected side is going to be moving fine, but the affected side is not going to move very far at all. Pleurisy or pain, anxiety, cyanosis, cough, you're going to have a dry, non-productive cough. Tracheal shift away from the affected side. What do you think your tactile fremitus is going to be? You're going to have a decreased tactile fremitus. Percussion notes, dull. Breath sounds, they're going to be diminished. You won't be able to hear breath sounds through that additional fluid. Early in the pleural effusion, you're going to have alveolar hyperventilation. At some point, that patient's going to deteriorate. They're going to get tired if the pleural effusion is not corrected, which can lead to or will lead to ventilatory failure. And we will need to intervene with our big guns at that point. When we look at hemodynamics, you're going to have an increase in pulmonary vascular resistance and your pulmonary artery pressure. So the right side of the heart is going to be increased, and on the left side of the heart, you're going to have a decrease in pulmonary capillary wedge pressure. So again, the lungs are the issue. Everything behind the lungs is going to increase. Everything beyond the lungs, the pulmonary capillary wedge pressure, which measures the left side, is going to be decreased or normal. But that is one way that we can look at it from right up front. We'll dive into those a whole lot more when we spend more time with hemodynamics. But just start with the right side, you're going to see things increased. The left side of the heart will be decreased or normal. Chest x-ray, ideally with a pleural effusion, we want to lay that patient down from being upright in a PA to lateral for that patient, for us to be able to identify that that fluid is flat through the lateral x-ray. So a pleural effusion that is less than 300 milliliters cannot be seen in an upright chest x-ray. That is why we want to do a lateral chest x-ray. One of the big things that we will see on the affected side is you will not see any costophrenik angles. That's one of the big things that you will not see when it comes to a chest x-ray, especially in an upright. This is what we want to see. We want to have a lateral chest x-ray. This is overexposed. We don't want this to be so bright. But this line right here, you can see this line right here where you have fluid accumulating on that lateral side. That is why we want to see these patients laying down. We want to see them laying down. If I were to have a patient that had a pleural effusion on this right side, which side would I want to lay them on so that they can oxygenate and ventilate the best? How would I position my patient so that they can oxygenate? There's a better way to ask that. I would want to position them with the left side down. Left side down. When we look at general management, we look at, should we do a thoracentesis? Again, if our pleural fluid is greater than 500 mLs, if our pleural fluid is greater than 500 mLs, then we will typically go ahead and get or perform a thoracentesis. We want to identify if the fluid is transudative or exudative. If it's transudative, fix the underlying issue, whether it's the whether it's CHF or right-sided heart failure. We want to fix those first. If it's a liver issue, we want to get the patient on the right medications so that they can preserve their liver as much as possible. If they are on peritoneal dialysis, we want to make sure that they do not miss any of their appointments so we are doing lots and lots of education when it comes to organ systems that aren't even inside the thoracic cavity. So again, identifying if it's transudative or exudative It will help us identify how we're going to treat the cause. Antibiotics, are we going to get a sputum, not a sputum, but a pleural fluid culture? Are we going to get a sensitivity? Are we going to do a gram stain? What are we doing here? Should we use a chest tube? How much fluid are we draining? Identify when we would use a chest tube versus a thoracentesis. And then we already talked about it already, but is the fluid transudate or exudative in nature? When we look at the respiratory protocols, we're going to give these patients oxygen. We're going to do some lung expansion to help fix or prevent any atelectasis, or further prevent, or we're going to give these patients oxygen. We're going to make sure that they can maintain their oxygen. We're going to use some lung expansion therapy so that we can keep that atelectasis at bay as much as possible. And if it gets really bad, we can use mechanical ventilation so that we can maintain positive pressure in the alveoli so they are not being pressed on and collapsed. And then the pleural desis, this is another video towards pleural desis. Remember, we talked about this. This is the talc powder that's being infused into the pleural space, causing that inflammation, and that inflammation will close off wherever the leak is. So, like I said, I will upload the PowerPoint itself so that you can access the pleural desis video and the thoracentesis video. But this is it when it comes to disorders of the pleural space. We talked about the pneumothorax. We talked about the pleural effusion. These are two disorders that will impact the pleural space. Both of them could end up with a chest tube. Both of them could end up with a pleural desis. If it's an air issue or a pneumothorax issue, we could do what's called a needle decompression. If it's a fluid issue, we can do what's called a thoracentesis. So a couple of things to differentiate between those two disorders.